This PowerPoint covers the assessment of eyes, ears, nose, mouth, and throat, chapters 14, 15, and 16 in your book. This is just a picture of the anatomy of the eye to just refresh your memory in the names of the different anatomical structures. This picture represents the assessment, which is called the cardinal movements of the eye. These movements are mediated by cranial nerves 3, 4, and 6. We'll learn more about those when we cover neuro towards the end of the semester, but it is one of the assessments that you will perform when you do your eye assessment. There are three different visual reflexes in the eye. The first is the pupillary light reflex, which is a normal constriction of the pupil when exposed to bright light. It's mediated by cranial nerve 2 and 3, and the normal response that you would see is constriction of the pupil when exposed to bright light, and then dilation of the pupil when that light is removed. The second one is fixation, and this is the ability of the eyes to stay focused on a faraway object as another object is brought closer into the visual fields. So, an example of this would be to have your client focus on an object, maybe on the wall on the opposite side of the room, and stay focused on that object as you take, like, your finger or a pen or something and draw it closer to their field of vision. So, they would stay focused on the far away object, although was an object coming into their closer vision. And the last one is accommodation. So this is the ability of the lens to adapt for near vision. So how you would test this would be to put your finger or pen light or pen in front of your client's face and ask them to stay focused on it as you draw it towards their face. So the normal response would be that the eyes would turn inwards as you bring the object towards their face, and you would see constriction of the pupils. So, subjective data that you want to obtain from your client pertaining to vision, any difficulty in sight or blurred vision, blind spots, any problems focusing or clouding of objects, any spots in their visual fields, halos, rainbows, rings around objects, blind spots, loss of peripheral vision, or night blindness. The nurse is obtaining a focused review of a patient's eye function. Which statement by the patient would require emergent medical attention? Number 1, I see flashing lights and spots. Number 2, my eyes feel tired all the time. Number 3, my eyes get watery when I'm gardening. Number 4, I'm having trouble seeing when I drive at night. So let's break these down one at a time. The first one could possibly be an indication of a detached retina, which is indeed an emergency medical condition. Eyes feeling tired could just be simple eye strain, eye fatigue. So maybe you would make the patient a referral to an optometrist for an eye exam. Watery eyes when gardening would be more of an indication of allergies, and trouble seeing at night could be an indication of problems with night vision. And so that would be another indication for a visit to an optometrist. But number 1, seeing flashing lights and spots, is an indication of, like I said, a detached retina, which would require emergency medical attention. So you would want to refer that client directly to the emergency room. A few more examples of subjective data to obtain during your health history: any generalized difficulties with vision, pain in the eyes, strabismus, diplopia, redness, swelling, watering discharge, history of ocular problems, glaucoma, use of glasses or contacts lenses, and self care behaviors. And the next several slides go more detail into these different subjective questions. As with any other body system, any positive response to any of these questions would require asking those PQRST questions. So, for your physical assessment of the eye, you generally are going to have the patient standing for their vision screening, and that's when you would use the Snellen eye chart. And then for the remainder of the screening, you would have them sitting on the edge of the exam table and complete the remaining steps. The Snellen eye chart is the chart that's used to test visual acuity. You guys will have a chance to test each other's vision in lab. The chart needs to be put in a well lit spot at eye level, and generally there is a line on the floor that is 20 feet from the chart. You'll have your client cover one eye at a time and have them read the line that is the smallest that they're able to read without making any mistakes. If they wear glasses or contacts, you want to make sure that they have these in place during the exam. If they're just reading glasses, then you would have them remove them. If the client is unable to see even the largest letters on the chart, you would move them closer to the chart and then record the distance. For instance, if you had to move them 10 feet away from the chart instead of 20 in order to read the largest letters, then you would record their vision as 10/20. If they have really low visual acuity and you have to move them, say, 2 or 3 feet from the chart, then you would assess whether they can count your fingers at a certain distance in front of their eyes. To test the external ocular movements, also known as the six cardinal positions, this is that picture that I showed you at the beginning of the PowerPoint, where you would use an object and have your client track it through those six cardinal fields of vision. And here's another example of the six movements that you would move the eyes through with whatever object. Like I said, you could use your finger or a pen or your pen light. A normal finding for this exam would be that the client can follow the movements without any nystagmus. It is normal in the extreme lateral gaze to have some mild nystagmus, but any other nystagmus at any other position is not a normal finding. Next, you would do just a general inspection of the eye, the external eye structures, and the eyebrows. You want to pay special note to facial expression, any lid lag. You want to look at symmetry between the eyes, symmetry between the eyebrows. Note that both eyebrows are present and symmetrical movement as expression changes. Normally, upper eyelids overlap the top part of the iris and approximate, which means the top and the bottom lids will meet completely when the eyes are closed. The palpebral fissures, which are the slants on the lateral parts of the eyes, are horizontal, although Asians normally have somewhat of an upward slant. Eyelashes should be evenly distributed among both upper and lower lids. Eyeballs should be aligned normally with no protrusion or sunken appearance. Inspecting the conjunctiva and the sclera, using your thumbs very gently, slide the lower lids down and ask your client to look up. Inspect the exposed area. The eyeball should look wet and glossy. You should be able to see small blood vessels. There should be no yellowing of the sclera. Normally, the lower lids are slightly pinkened. Note any color changes, swelling, or lesions of the eye or the lids. Inspect the iris and the pupil. The iris is normally flat with a round, regular shape, and coloring is usually even. Note the size, shape, and equality of pupil size. Normal pupils are round and regular, equal size in both eyes. This is when you would test that pupillary light reflex. So slightly darken the room. Ask your client to stare at the wall on the other side of the room. This should dilate the pupils. And then take your pen light and slowly advance it into their line of vision, and you should see the pupils constrict. Lastly, you'll test for accommodation. Turn the lights back up in the room if the room is dim. Have your client focus on the wall opposite of where you are in the room. This will dilate the pupils, and then bring whatever object you're going to use in front of their face and have them focus on it and then move that object towards their nose. So the normal response to this would be constriction of the pupils and convergence of the eyes, or eyes staying focused and turning in on the object that you are drawing towards their face. To record this normal response to all of the assessments we just talked about, you guys have probably seen this PERRLA, or PERLA. What that means is pupils equal, round, react to light, and accommodation. This is a documentation that you will commonly use. The nurse is assessing the pupils of a patient with a pen light. Which finding would be considered normal? Number 1, both eyes cross when exposed to the light. Number 2, the patient's pupils are fixed and dilated in response to light. Number 3, both pupils dilate in response to the light. Or number 4, both pupils constrict in response to the light. So your normal assessment finding for assessing the pupillary reflex is that pupils would constrict when exposed to light. Here's an example of a sample narrative charting regarding your eye assessment. So you would summarize your subjective data. Vision reported good with no recent changes. Denies eye pain, inflammation, discharge, or lesions. Wears corrective lenses. Last eye exam 1 year ago. Test for glaucoma at that time was normal. And then you would summarize your assessment findings in your objective data. Snellen chart, OD 2020, OS 2020, that's right eye, left eye. EOM, that's extraocular movements intact. Brows and lashes present and symmetrical, no ptosis. Conjunctiva clear, sclera white, and there's that PERLA, PERRLA, pupils equal, reactive, round, reactive to light, and accommodation. So your summary for your eye assessment: test visual acuity using the Snellen eye chart, inspect extraocular movements with the diagnostic position test, inspect external eye structures, inspect anterior eyeball structures. So here's a list of potential abnormal findings. You can refer to the chapter in your book. There are some pictures representative of some of these findings so that you can see some abnormals. But just for review, some abnormal findings. Okay, so next we're going to move along to the ear. This is just a picture of the external and internal anatomy of the ear, just for a refresher. I'm sure you guys have all seen this at some point in time. The ear is divided into the external ear, or the anatomy that you can see externally on the side of the head, the middle ear, and the inner ear. And it's important to know the differentiation and which parts of the anatomy are located in which section of the ear. So here's a breakdown of what's included in each section: the external, the middle, and the inner ear. So the external ear, like I said, is pretty much everything that you can see on the outside of the head, through the auditory canal, and to the tympanic membrane. The middle ear is where sound vibration is conducted, and the job of the middle ear is to protect the inner ear. The inner ear is where all of your sensory organs for hearing and equilibrium are. Next, we're going to talk a little bit about hearing loss. So there's a couple different kinds of hearing loss. The first one that we're going to talk about is conductive hearing loss. So this involves some sort of mechanical dysfunction of the external or inner ear. So it could just be a partial loss if they have a hard time hearing sound amplitudes. It can be caused by impacted cerumen or earwax, foreign body lodged in the ear, perforated tympanic membrane, maybe some pus or fluid in the middle ear, otosclerosis, which is a decrease in the mobility of the ossicles, which are contained in the middle ear. The second kind of hearing loss is sensory neural or perceptive hearing loss. This signifies some pathology of the inner ear, cranial nerve 8, or the auditory area of the cerebral cortex. So with patients that have sensory neural hearing loss, even increasing the amplitude, so increasing the volume of the words, may not enable the person to understand what you're saying. May be caused by pres- presbycusis, which is a gradual nerve degeneration that occurs with aging. It can also be caused by some drugs, which are considered ototoxic drugs. So they're toxic to the auditory areas or the cranial nerve, and it affects the hair cells in the cochlea. You can also have a mixed hearing loss, which would be a combination of conductive and sensory neural types in the same ear, but this is less common. The most common kind of hearing loss that you are going to run across is conductive hearing loss. Our equilibrium is controlled by the labyrinth in our inner ear. It's constantly feeding information to our brain about our body's position in space. If the labyrinth ever becomes inflamed, it can feed incorrect information to the brain, which would cause that staggering gait or a sensation of spinning or whirling, which we call vertigo. So, some special considerations with children. An infant's eustachian tube is relatively shorter and wider, so it's easier for them to develop infections of the middle ear. Otitis media is one of the most common illnesses seen in children. The most important cause is environmental. Children in high risk groups are exposed to multiple pathogen and total bacterial load is high. You see your highest incidence and severity in children in North America, New Zealand, and Northern Europe. So, what subjective data do we want to obtain when it comes to our assessment of the ear? Any ear ache or pain in the ears? And remember, if they have a positive response, you want to ask more questions to obtain the most data possible. Any ear infections as an adult or in childhood, frequency of those infections and how they were treated, any discharge from the ears, any relationship between discharge and ear pain. Difficulty hearing, and if you get a positive response, you would want to ask questions such as onset, character, what situations does it seem the most significant? Do people seem to shout at you? Do ordinary sounds seem hollow, like as if you were underwater? Have you recently traveled by airplane? And do you have a family history of hearing loss? Lastly, any efforts to treat hearing loss, such as do they use a hearing aid or other device to assist in their hearing? And then any coping strategies. So, how does this hearing loss affect their daily life? Does it impact their job? Do they have any feelings of embarrassment? And how do friends and family react? So, a couple things to keep in mind while you are just doing your general health history taking. You could pick up on some clues just from normal conversation that would indicate hearing loss. If you notice that your client appears to be reading your lips rather than looking you in the eye when you're talking, if they're frowning or they seem like they're straining to hear you, posturing of their head, so maybe turning one ear towards you to be able to hear you better, misunderstanding questions or asking you to repeat. If their speech sounds garbled, especially if vowel sounds are distorted, if they have an inappropriate loud voice or maybe a flat, monotonous tone to their voice. Questions related to environment. Are they exposed to any loud noises at home or on the job? Do they use headphones, earplugs if they are exposed to those noises, heavy machinery, loud, persistent music, gunshots, all the things like that. You want to make sure that you ask about tinnitus, which is that ringing or buzzing in the ear, and also vertigo, feeling that the room is spinning, dizziness, things like that. And lastly, self-care behaviors. Do you clean your ears? When was the last time you had your hearing checked? If they do note any hearing loss, do you have a hearing aid? How long have you had it? Do you wear it? For your physical assessment of the ear, you're going to mainly do inspection and palpation. So first you want to start by inspecting and palpating just the external ear. So the ears should be equal size bilaterally. They should be placed evenly on the head. They shouldn't be low set. the skin condition, the skin color should be consistent with their facial color. There should be no lumps or lesions on the ears. You might notice that some people have what's called that Darwin's tubercle, which is a small, painless nodule at the helix. This is common and it's not significant. You want to assess for tenderness, so move the pinna, push on the tragus of the ear. They should feel firm. Those movements should not produce any pain in your client. And then you also want to palpate the mastoid process, which also should produce no pain in your client. There should be no swelling, redness, or discharge in the auditory meatus. You might notice some cerumen or some earwax. That color could vary from a grayish yellow to a light brown. Next, you want to test for hearing acuity. So, some of that screening begins during history just by figuring out how well they hear speech. You can ask your client directly if they have difficulty hearing. If the answer is yes, then there is certain audiometric testing, or you could refer them for a more specific hearing screen. If the answer is no, then you would use a whispered voice test. So, what you would do there is have your client plug one ear and move their finger back and forth in that ear while you whisper 2 or 3 words in the other ear, and then ask them to repeat back to you. And you would do that in both ears. And again, here's the steps for that whispered voice test. The nurse is assessing a patient who has a hearing impairment. How should the nurse communicate with this patient? Number 1, use a low tone voice and speak slowly. Number 2, use a normal tone of voice and speak slowly. Number 3, speak loudly with normal rate. Or number 4, face the patient and speak slowly. So, looking at these, you probably could say that a couple of them are correct. Number 1, you would not want to lower the tone of your voice because it's going to make it harder for the client to hear, but you would want to speak slowly. Number 2, you would keep the tone of your voice normal and speak slowly. Number 3, you would not want to speak any more loudly because that can be considered insulting. And number 4, you definitely want to face the patient. So if I had to look at these, I would say that 2 and 4, a combination of those 2 answers would probably be right. You want to face the patient, you want to be in front of them, you want them to be able to read your lips if they need to, use a normal tone of voice, and speak slowly to them. So here's your sample narrative charting for your ear assessment. The subjective data is summarized. Patient states hearing is good, denies earaches, infections, discharge, hearing loss, tinnitus, or vertigo. And your objective data is summarized in skin intact with no masses, lesions, tenderness, or discharge, whispered words heard bilaterally. And summary of your physical assessment, start with inspecting the external ear and then testing hearing acuity. So moving on to the nose, here is a picture of the anatomical structures of the nose. This picture is also in your textbook if you need to refer to it, maybe in a bigger size, because I know this picture is really little. Our nose has 2 functions: to warm, moisten, and filter the inhaled air, and it is also our sensory organ for smell. Here's a visual picture of the sinuses and where they are located within the head. Subjective data regarding the assessment of the nose includes discharge, frequent colds, upper respiratory infections, sinus pain, trauma, epistaxis, which is nosebleeds, any allergies, or any altered smell. And the next several slides go through all of the subjective data in a little bit more detail. Your physical assessment of the nose begins with inspection and palpation. You want to look at the external structures. The nose should be symmetric, midline, and in proportion to other facial features. You're inspecting for deformity, asymmetry, inflammation, or lesions in the skin. You'll test patency of the nostrils by closing each side and asking the person to sniff inward. You can also test sense of smell, which is mediated by cranial nerve 1. It's not usually a test that you do during a routine examination, but you can do it in the same way. You would have the client occlude one side and then place a familiar scent underneath their nostril and ask them to tell you what the scent is. They would have their eyes closed while they were doing this. So this is just a picture of examining the internal structures of the nostrils using a nasal speculum, which can be placed on the end of an otoscope. Lastly, you would palpate the areas of the sinuses for any tenderness. And here's a list of potential abnormal findings of your assessment of the nose. Refer to your textbook and the section on abnormalities for more details regarding any of these abnormal findings. So lastly, we're going to cover the mouth and throat assessment. So here's a picture of the anatomical structures of the mouth and throat. The mouth is the entryway to our digestive system. It's also the entrance to one of our airways. It's used for mastication, swallowing, speech, and taste. This picture shows the location of the salivary glands. Subjective data for mouth and throat includes asking about sores or lesions, any presence of sore throat, bleeding gums, any recent toothache, hoarseness, dysphagia, which is a problem swallowing, altered taste, any presence of smoking or alcohol consumption. What are their self care behaviors, dental care pattern? So, for instance, when was the last time they saw the dentist and do they go routinely? And use of any dentures or appliances. So the next few slides just provide some more detail regarding that subjective data. Always remember that any positive response to a subjective question requires you to ask for more detail using those PQRST questions. You guys are going to get so tired of hearing me say PQRST, but just stick it in the back of your mind. You always want to ask more questions if you get a positive response. So your assessment of the mouth, if you're not wearing gloves, I would definitely wear gloves for this part because you are going to be placing your fingers in your client's mouth. So you're going to begin with anterior structures and move posteriorly. Use a tongue blade to move the tongue from side to side to be able to optimally visualize, and then use your pen light too so that you can see the internal structures of the mouth and the throat. You want to inspect the lips for color, moisture, cracking, lesions. Retract the lips and look at the inner surface of the lips. Look at the teeth and the gums. Normally the gums would have a pink color. Gum margins should be tight and well defined. You want to look for swelling, bleeding, discoloration of the gums. Next, inspect the tongue. You're looking for color and surface characteristics. Ask the client to touch their tongue to the roof of the mouth so that you can see the underside of the tongue. With your glove, hold on to the tongue and pull it out and look at it side to side. Inspect for white patches or lesions. Normally, you would not see any. Always wear gloves, like I said, to examine the internal structures of the mouth. Here's your anatomical picture, which shows the structures of the throat. The +1, +2, +3, +4, that is just pictured here is how you would grade tonsils. So if your client has their tonsils, you would use this scale to grade the presence of them. So normal +1 would be normal, all the way to +4, which would be tonsils that were swollen and touching in the middle of the throat near the uvula. Here's your sample narrative charting for your subjective data for your nose. Denies discharge, sinus problems, obstruction, epistaxis and allergy, fractured nose in high school sports, treated by MD. Mouth and throat subjective data denies pain, lesions, bleeding gums, toothache, dysphagia or hoarseness, tonsillectomy at age 8. So, the absence of tonsils would definitely be something you would want to note when you're doing your assessment of the throat, and that would be a variation of normal finding. Visits dentist semi annually or every 6 months, flosses daily, no dental appliances. Summary of objective findings for nose, mouth, and throat. Nose, symmetric, no deformity or skin lesions. Nares, patent, no discharge or lesions. Sinuses, non tender to palpation. Mouth, can clench teeth. Mucosa, pink, all teeth present. Tongue, smooth, pink, protrudes midline. That protruding midline is one of our cranial nerve tests that we'll do, so we will talk about that again later in the semester. Throat, mucosa pink, uvula midline, tonsils present, gag reflex present. And again, here is your summary checklist for your nose, mouth, and throat exam. The most common abnormalities you're going to find associated with lips would be cleft lip or also the presence of the herpes simplex lesions. So I encourage you to look in your book and look at the pictures of these two findings. Some other images you may want to look at in your book: abnormalities of teeth and gums, baby bottle tooth decay. So, this would be an instance where a child is left with a bottle with sugar containing usually juice, and they're left with it in their bed for multiple nights. There's a lot of you see, unfortunately, a high incidence of this tooth decay, and what you see is extreme shortening of those front teeth. Also, malocclusion, dental caries, gingivitis, and meth mouth. So, like I said, look in your book, look at these pictures, kind of familiarize yourself with them. Some more abnormalities of the tongue. Again, look in your book, familiarize yourself with these pictures. These aren't things that you're going to see very commonly, but sometimes it's nice to put an image with a word that you may read in a chart. And lastly, some abnormalities of the oropharynx. So, cleft lip could extend all the way back to include the palate, bifid uvula, oral Kaposi's sarcoma, and acute tonsillitis and pharyngitis. Again, all of these terms have pictures in the book, so take a look at them. Put the words with the pictures. I would strongly encourage you guys to view the Evolve videos for these assessments. It will really help you when you come to the lab portion and have time to practice these assessments on each other, especially the parts that have to do with the assessment of the cranial nerves, because we will cover this again at the end of the semester, so you'll hear it a couple of different times. And then one of your bigger test outs in lab does include the testing of all of the cranial nerves. So it's nice to look at it now, and then, like I said, we'll have it again later in the semester. You'll get to practice it a couple of times, but you'll become a lot more familiar with it, and it will flow easier for you if you look at it a couple different times. So again, in Evolve, with your student resources with this textbook, there are video examples of the assessments of all of these different body parts. So let me know if you have any questions. You can reach me by email. Hope you guys have a good couple weeks.